is Finn Voices on the Healthcare Now radio, where we highlight and amplify the voices at the forefront of health innovation that improves people's lives. Join us for an inside look at the changemakers driving conversation and answering the most important questions in healthcare today. Thanks for joining us.
Hello, everyone, and thank you for tuning in. I'm your host, Beth Friedman, Senior Partner at Finn Partners. I'm based in Atlanta, Georgia, and my guest today is Mark Van Sumeren. He is the General Manager of Healthcare at LogicSource. Mike and I were brainstorming recently about one of healthcare's biggest and rather urgent challenges, and that is profitability and costs, especially post-COVID. So Mark is a supply chain expert in this space, and he's got a rather unique perspective on the current challenges and the opportunities for innovation. Mark, thrilled to have you as a guest today on Finn Voices. So welcome to the show.
Well, thank you, Beth. It's my pleasure to join you, and I'm honored to be a part of your guest series. Thank you.
Super. Absolutely. Yeah, I think last time I saw you, we were in Nashville having some whiskey tasting, I believe.
yeah, we had a little fun. That was a great time, a great conference, and it was great to see you there and work with some folks there as well.
Super. So speaking of conferences, I was just at the AHA, American Hospital Association Summit in Seattle. Very enlightening. I hadn't been for a few years, so really enjoyed it. I did have the opportunity to check into some sessions about cost reduction, and two of those were really focused on supply chain. So it was a bit eye-opening for me. I know you're an expert here, but I learned quite a bit talking about innovation and just really how we should clean up some of those legacy processes there. And then on the heels of that, yesterday I just read that Kaufman Hall report. I think it was the June report. And it said that non-labor expenses per day have risen 4% per month, like month over month, due to inflation. So this is definitely an area we need to innovate and look at. You're an industry veteran. You've got experience in supply chain, both in healthcare and out of healthcare, which we're going to chat about today. So, question, do you think this spot is ripe for innovation? What other areas are good for innovation in healthcare right now? And just get your insight on that.
Well, great. Thank you, Beth. First of all, I'm surprised, encouraged by one statement you made there in particular, that at an ACHE conference, they were talking about supply chain. We've come a long way to be at the table and a part of the discussion. And I think the pandemic had a lot to do with that, but certainly the challenges that we have on margin improvement and the like. But what's interesting, when you say innovation, a lot of people think about innovation in healthcare being clinically oriented, a new device or a new therapeutic that allows us to innovate in the way that we deliver clinical care. What we lose sight of, if we go back to the roots of innovation in business, it's about process improvement, process innovation. I was surprised in my preparation for talking with you today. I went back to what was considered the Bible of process innovation, Hammer and Champion, you remember? 30 years ago this year. It's 30 years old.
Wow.
But if you think about that, and there was a companion, actually a competing piece, Thomas Davenport wrote about process innovation, actually in 92, so a little bit before that. But when I think about innovation in healthcare and process innovation in the supply chain in particular, we really haven't innovated in the last 20 or 30 years. And the last real innovation on process as it relates to healthcare supply chain and procurement was when we took materials management out of the basement, brought value analysis into the equation, and started thinking about how do we leverage our procurement, our sourcing skills around medical devices and implants. That's not innovation anymore, because we've been doing that for 20 or 30 years. So where is the opportunity for innovation today? And where I see it is almost the last frontier. It's those indirect non-clinical purchases that run outside of the GPO, run outside of the supply chain organization, but become core to running the business of healthcare or a retail or a consumer products company. It's the information technology, it's marketing, it's facilities, it's media buys, it's real estate. It's all of those things that are required to keep the business running. And we're doing it the same way we've done it for the last 20 or 30 years, which is largely we're not paying a lot of attention to it. And I think this area is ripe for innovating our business process around the supply chain, procurement, sourcing, et cetera. Tremendous.
So you're right. Yeah, so you're right. So the one session I went to at the conference was it was a new title for me. It was Chief Clinical Supply Chain Officer or something like that, right? So to your point, we've been focusing a lot in supply chain on the clinical side.
And rightfully so, Beth. Right. It's big dollars. Yeah.
Yeah. But yet, and the value analysis, right? And this physician talked about, looking at different types of hip implants, right? And looking at the outcomes. And that's all that value analysis you're talking about. But to your point, what I think I heard you say was that what we haven't looked at and what we desperately need to is what about all the other stuff? What about what we need day in and day out to keep the lights on in our hospitals? And, why aren't we looking at that? So I think that's where you're saying we've got some area for improvement there.
Well, we absolutely have an area for improvement. And a lot of it first comes with an understanding and awareness and then visibility to the issue. As we talk with chief financial officers, chief operating officers, and the like of health systems, it's surprising to most, and if not all, that those expenses, things that don't ever touch patient care, but are required to operate the business, are often 20% of net patient revenue. That's a significant number, especially when, the way that healthcare manages sourcing, contracting, procurement, supply chain is we rely appropriately very heavily on our chief supply chain officer, our chief procurement officer, and our group purchasing organization. But if we look at those categories, those indirect categories that I'm referencing here, at best, 25% of those products, services are captured under a GPO contract and managed by your chief procurement officer. That leaves a lot of gray area, a lot of expense.
So you talked about the data-driven insights and the value analysis that we've done on clinical pieces. Let's talk about that as it relates to the non-clinical. Let's talk about a little bit about data intelligence to give us better outcomes for innovation on the non-clinical spend.
Right. Thank you, Beth. And this is where the opportunity lies. And the data become critical, and the innovation needs to occur because even though one would argue that value analysis, contracting, procurement around a complex medical device
organization, correct?
Yes, absolutely.
Okay, cool. So let's dive into some of the value analysis we're already doing on the clinical side.
Arguably could be more complicated than doing the same thing for a media buy. However, the innovation comes because we can't apply the same approach to benchmarking, data analysis, and contracting in these areas that we apply for clinical products. And here's why. If we look at these areas, we cannot simply say, here are the minimum requirements or the ideal requirements like we do for a device when we're evaluating hip implants and say, give me your best unit price. If we're evaluating a media buy, a landscaping contract, or any of the other benefits contracts within an organization, what's the unit cost benchmark that's applicable at any one of those? It doesn't lend itself. There are other considerations that have to be taken into place. And so when we talk about a data-driven approach to sourcing, contracting, and procuring indirect services, we've got to move past the concept that we can boil it down to a unit cost, because the units of measure are never clear, and the scope and the attributes around the delivery of that service become absolutely critical to understanding what's the right contract, what's the right term, what are the right terms and conditions to move forward with that contract. And it can't be reduced down to a simple cost per unit calculation or benchmark.
Yeah, there's a lot of different variables. And I feel like we've probably figured it out on the clinical side, but let's talk about figuring it out on the non-clinical side, because that's where your expertise is going to come in, I think. We've always thought of our industry as unique in healthcare. I've often used that phrase myself, having worked in a hospital for a long time. But there are parts and pieces, as you allude to, that are not unique, right? They're things that we're doing to keep the lights on, their day-to-day services. Can you guys give us an example? You mentioned landscaping services. Can we dive into that a bit?
Let's do that. And
okay.
Where if we simply lift and shift how we approach what we do on the clinical side, whether it be for sutures or knee implants, if we simply lift and shift how we do that to how we would procure landscaping services, here's where the problem lies, is landscaping services. There are a whole number of dimensions, but let's just pick one. You're in Atlanta. I'm up here in Michigan. Okay. The grass is different. Okay. So are you going to evaluate a contract for a health system in Ann Arbor versus one in Atlanta based on what the hourly rate is for the person? Are you going to do it based on the square footage or square yard of sod that you're going to be mowing? That's grossly inadequate. You can't make those comparisons. It's a locally derived, locally serviced application. So you need to understand what's relevant in the Atlanta market if you're going to contract for Atlanta, and Ann Arbor if you're going to do it for Ann Arbor. That's great. Okay, so we'll look at benchmarking landscaping services among healthcare systems in Atlanta if we're going to make that comparison. Okay, well, we've already said, and if you'll accept my argument that we're not very good at sourcing and contracting for those services, and we're going to compare ourselves to other health systems in the Atlanta market. First of all, we've limited the sample size, and the bar we have set for ourselves isn't very high. Why aren't you comparing yourself against other business entities in the Atlanta market or the Detroit market or the Albuquerque, New Mexico market, so that we understand who's providing that service, what's the level of service that's provided, what's the nature of the services based on the climate and other factors, and then make an evaluation for what is a really good contract for landscaping services for that particular organization. And by the way, all these organizations outside of healthcare are contracting with the same organizations that we need to in that market. And they're probably, at least our experience is showing, that they're getting better results in terms of both cost and quality of what they're contracting for.
Yeah, absolutely. And not to mention, our growing season is way longer than yours, right? So
yeah, but
take that into consideration.
What about, let's compare snow plowing services?
Oh,
well at that out here in Ann Arbor.
It all balances out, right?
Yes.
You are listening to Finn Voices on Healthcare Now Radio, and my guest today is Mark Van Sumeren, General Manager of Healthcare at LogicSource. So, jumping back in, Mark, negotiating these type of indirect spending, non-clinical agreements or contracts seems like a straightforward way to free up some money for our health systems in the country. But I'm curious if there's any impacts on quality or value in healthcare. Like, what about those other pieces of the quadruple aim?
Yes. In fact, this is what really excites me as we address the indirect, the non-clinical spend, which I think, first of all, gives us a great margin improvement opportunity. But at the same time, both directly and indirectly, it allows us to improve our service delivery or the quality of our services. So let me answer both the direct and the indirect. As we consider what is the best contract for a particular indirect service for a health system, we're not only considering what's the unit cost or the best price that we can get, it's do the critical characteristics of that contract align with what the health system is trying to accomplish, its strategies, its direction, what's important. Take an example as simple as window washing in a children's hospital. Okay. If the contract can include that the window washers will dress up as Superman or some other action character and still drive a very competitive price, that can start to impact the experience for our customers, the patients. Okay. Here's another example, and this is something that we work through with a client, regardless of industry, doesn't matter. But we work through their benefits administrator, and who we're working with on benefits, saved well over $2 million a year on their benefits costs. And at the same time, they were able to expand the scope of services that they were offering to their employees and their benefits. So it was a win-win all around. Better service at a lower cost. That's the direct impact. The indirect is what really gets me excited. As I've observed the industry and worked with the industry over the last year, coming out of the pandemic, how many times have we had to reduce access to care because we didn't have the people, we didn't have the margin to do it, revenue was exceeding expenses were exceeding our costs. And so we had to put the brakes on of how quickly we could bring services back to pre-pandemic levels. Well, if we free up significant dollars out of what we're spending on indirect, with at worst maintaining quality, hopefully improving quality of those services, we've freed up a lot of cash to put back into the clinical side of the business. Mm-hmm. And it's hopefully we can get access back to at least where it was pre-pandemic, hopefully even expand it further, because the demand certainly is there for health services.
So freeing up dollars from your window washing and your landscaping services and your benefits administration to support that new MRI machine or, a new cardiac cath lab or something, right?
Absolutely. Absolutely.
Yeah.
And it really gets back to rethinking how we source, contract, and purchase these services. In some regards, the way that we invest and do that effectively on the clinical side. In some regards, it's got to be different because of the nature of these products and services are different. And again, we're competing against non-healthcare entities to get the best price, cost, service result out of that negotiation, if you will.
Speaking of the negotiation, so I understand, we all know that GPOs, group purchasing organizations, have done most of those negotiations on behalf of our health systems on the clinical side. Are GPOs helping with this non-clinical indirect spend? Like, kind of what's their role today in this piece, in this piece in particular?
That's a great question, and an important point for us to elaborate on with our audience here, in that group purchasing organizations, along with the supply chain organizations within the health system, have played a vital role in getting us to this point with regard to clinical products, medical devices, medical supplies, et cetera. What we have found, however, is that of this spend, which is pretty significant, a fifth of the expense base, in the best circumstances, GPO contracts address 25% of it. They just don't get there. And the reason why they don't get there is the nature of these products and services don't lend themselves to the traditional GPO model, which is national or regional contracts, selected vendors, established contracts, terms and conditions, prices, almost a buy off of this contract. That doesn't work for these types of services that are either highly localized with localized vendors and or very much contingent upon what are the very unique circumstances around that service in that particular location with that health system. They do not lend themselves to pre-established contracts that the one size fits all or the couple sizes fit others that you see there. And so they fall outside of these, and it really would require a change in the GPO business model, in my view, in order to address them effectively.
Right, to get down to that local level that we
Yes.
talked about.
Yeah,
for sure. So, there was another takeaway from the AHA event that I wanted to ask you about. And this is something I wasn't familiar with, but I heard that a lot of this purchasing of these type of indirect items are done at the department level versus out of that, I'm going to call it materials management, right? Out of the supply chain procurement department. Is that true? Is that what you're seeing with your prospects and clients? And then is that best practice? What is best practice?
Well, we can talk about what's best practice in healthcare and what's best practice in corporate America. But to your first question, it is true. If we think about these indirect expense, and I'll just get, the broad categories: information technology, facilities, construction design, marketing, et cetera, et cetera. A lot of those are under the purview of someone, either a department head or a CXO. Benefits, responsibility of the chief human resource officer. IT, responsibility of the chief technology officer or chief information officer. Marketing is the responsibility of either the chief operating officer or the chief marketing officer. They're there because what has been important traditionally is that the services are organized and delivered to meet the very high level demands and needs of that department or that office. Absolutely critical. However, we've lost sight of the discipline, or we've not taken advantage of the discipline of strategic sourcing applied to those now very large and growing expenses. And for the most part, in healthcare, we haven't brought the chief procurement officer to the table, or they may not have the ability to manage that procurement spend in the face of the chief technology officer. Let's say, that's a pretty powerful position, and it has to be controlled in that way. Outside of healthcare, they're moving to that, where the chief procurement officer is responsible for 100% of the procurement spend.
Not to mention the time required, right? I think about all the departments in healthcare, in a hospital health system. That's a staffing issue too, I'm sure, right? This person,
yes,
the chief procurement officer, may not have enough staff with the expertise in non-clinical to really support that effort.
That's Beth, and you hit on something that's very insightful here. If a health system would to think about the resources they commit internally to, again, I'll use the phrase, the process flow of source, contract, and procure a hip implant or even a suture. There's a tremendous amount of resources internally that are focused on those three activities in the process. Now compare that to the resources they've committed to source, contract, and procure for these hundreds, if not thousands, of products and services that come through indirect. And they may have a person or two in the procurement office that, well, they know some about purchase services. The investment is dwarfed in these areas by what they're investing in the clinical areas. The investment in the clinical area is absolutely critical. My argument is why are you underinvesting in the indirect space?
Right. Needs to be a balance.
Needs to be a balance. Right. And we're finding that that investment is orders of magnitude away. Now, here's the other difficulty, that with the GPO and the supply chain organization, you have these resources that become category experts. You have people that have negotiated knee implant contracts, hip implant contracts, suture contracts, and have done it repeatedly through the years. Then you ask your indirect procurement specialist to negotiate a media buy if they get even asked to the table, evaluate a facility and design contract if they're even invited to the table. And how often have they done that in their career? Once every couple of years, once, 3 times? Compare that to having a resource available that there's a person that's all they do, and they negotiate those contracts for multiple organizations several times during the year.
And just the wisdom alone you'd learn the first or second time doing that, right? Then you could incorporate those best practices into your workflow, into your organization.
Yes, particularly as we've argued here today, is that it's more than simply what the cost per unit is. It's what are all the dynamics that go into evaluating just how solid is that contract.
So we've got a few more minutes left. I think we've got 2 more minutes left in our conversation, Mark. Any final thoughts on today's topic, or maybe let's tie it back to some of those cost reduction and need to get that financial stability back in place in healthcare. Any final thoughts?
Yeah, Beth, if I can, I kind of wrap it up thinking about it this way. I put myself in sitting at the desk of the chief financial officer, for example, and the ones that I've talked to over the last year have conveyed that the 2024 budgeting process is the most difficult one they've ever had in their career. And it stands to reason, because we've got this pent-up demand for services. We've got constraints on revenue. We've had inflation, both on labor and supplies, that has outstripped revenue. Now, in years past, the CFO, and I'm going to overly generalize, but the CFO, when they see the gap between revenue and expense and the margin goal, is to go to the chief supply chain officer and say, I need $10 million from you next year. Go beat up your vendors and extract another $10 million out of them to fill this budget gap. They can't do that this time, because those same vendors that have been taking price cuts year over year over year have the same raw material and labor cost increases that they've been trying to, and they're saying, I need to do a price increase this time. Okay. So where's your degree of freedom to fill that budget gap? So we've got this, what we often call the go get. We've got this placeholder in the 2024 budget about go get that $10 or $20 million. And I would suggest to you here that the indirect space is a prime opportunity to build that roadmap as to where we can fill that budget gap that we have for this year.
So that's the go get category, I guess, of the year, right? Is there an award for that? The go get category of the award?
Yeah, there should be, for what these CFOs and chief supply chain officers have had to go through year over year over year.
Yeah.
And I think they need a new game plan. They need a new roadmap. And I think this offers that to them.
Well, hey, Mark, thank you for providing the new roadmap, right, to save some money, which I'm sure is good news for everybody listening. Very important right now, very valuable to our listeners. So thank you for sharing. Thanks for being on the show.
It's been a pleasure.
Absolutely. So the easiest way to reach Mark is on LinkedIn, and you can learn more about his company, LogicSource, at logicsource.com/healthcare. This has been Beth Friedman, Senior Partner at Finn Partners. Thank you for listening to Finn Voices on Healthcare Now Radio, where we talk about health information, health innovation, and all the technology in between. Until next time, wishing you all the best in health.
Finn Voices is brought to you by Finn Partners, a global marketing and communications agency working across industries and services. Whether inside our walls or on the front lines of health transformation, we stand together to create meaningful and measurable impact to the world around us. Learn more at finnpartners.com and follow us on Twitter @FinnPartners.